My name is Leslie McGill, and I am the CEO of MedicAlert here in Canada. And I want to welcome you very much to our first ever Health Hour Live event. We are very excited today. We have nearly 700 people registered for this event, which shows you how important this topic is to Canadians. There are many people joining us today who are among our subscribers and their families, so welcome to you. And there are those who are new to MedicAlert. So what I'd like to do is share a little bit more about who we are, what we do, and the role we play here in the healthcare system. So fundamentally, MedicAlert is a connector between the first responder community and other parts of the healthcare system, whether it's hospitals, whether it's community programs, whether it's clinics, or even home, where a great deal of caregiving actually happens in our community and in this country. You likely know us by our iconic bracelets. I have been wearing mine for almost 40 years, but we are so much more than a medical ID company. And we are a charity, and that's something that a lot of people also don't recognize in us. We were formed in 1961 here in Canada, so we are nearly 60 years old and have been delivering our services for a very, very long time. We are a significant team of individuals. We have a team of trained healthcare experts on staff, and these individuals manage a comprehensive individual database of health information that we share with your permission to paramedics, police, firefighters, other healthcare professionals in an emergency, and especially when people cannot necessarily speak for themselves in an emergency situation. Our research shows us that the faster that first responders have information in their hands, the more effectively they can treat you and perhaps even save your life. In the case of Alzheimer's and dementias, not only is knowing health history and emergency medical information really vital in the service that we provide, but we also manage the country's largest wandering registry. And this registry helps us to help first responders get people home safely. And that's a really important thing. And many of you have participated in our program and our wandering registry. And some of you have had the benefit of having someone come home safely. I wanted to take a moment to thank our Health Hour Live partner, the Alzheimer Society of Canada, for helping us to prepare for today's session. They will also continue to help us with ongoing information after this event. With nearly 700 registrants, we had more than 300 questions that we simply could not cover in an hour. So we will be working with our friends at the Alzheimer Society to get you the answers to all of the questions that have been asked in the coming weeks via multiple communications channels. That said, we did see some strong themes emerge in the questions that you shared with us that we will cover today in the event with our two extremely knowledgeable and exciting panelists. But before I introduce them, what I want to do is set the stage with a little bit of information about Alzheimer's and dementia statistics in this country. So currently there are 564,000 Canadians living with dementia, and that number is expected to nearly double in the next 15 years. There are 25,000 new cases of dementia diagnosed every year, and there are 16,000 Canadians under the age of 65 living with dementia today. 65% of those individuals diagnosed with dementia are women over the age of 65. Interestingly enough, and Don will concur with this, only 5% of the Canadian Institutes of Health Research's budget is invested in dementia research. There are 56,000 Canadians with dementia who are being cared for in hospitals, even though this is not the ideal location to care for them. And I know Andre will have a few things to say about the long-term care environment in that respect. And there are 1.1 million Canadians affected directly or indirectly by this group of diseases. And finally, Alzheimer's and dementia costs Canadians about $10.4 billion annually. These are really very compelling numbers, and COVID-19 has made things even more pressing for those living with Alzheimer's and other dementias, as well as their families, caregivers, friends, and loved ones. So I am delighted today to introduce our two panelists, two incredible experts from very different ends of the spectrum, but nonetheless experts that I have a great deal of respect for. I'd like to begin with introducing Dr. Donald Weaver, who is the director of the Krembil Research Institute at University Health Network here in Toronto. Dr. Weaver, or Don as I know him, is an internationally recognized researcher and leader in university-based drug design and drug discovery for neurological disorders. He has published widely in all aspects of brain-related drug discovery and has done so in the world's most prominent medical journals. He has designed and co-developed 2 drugs that have reached phase 3 human trials and has 4 others in preclinical development. And one of these drugs was the very first disease-modifying drug in the world to reach phase 3 clinical trials for Alzheimer's and dementia. So he is among the leading experts in the world on this set of diseases. So welcome to you, Don.
Thank you.
And Andre Picard is a health reporter. That seems like such a small way to describe you, Andre. And a columnist for the Globe and Mail, where he's been a staff writer for more than 30 years. He's also the author of 5 best-selling books. He's an 8-time nominee for the National Newspaper Awards, Canada's highest award for journalism in the country, and the past winner of the very prestigious Mishner Award for Meritorious Public Service in Journalism. He has been named Canada's Public Health Hero by the Canadian Public Health Association and Champion of Mental Health by the Canadian Alliance on Mental Illness and Mental Health. And he is also the recipient of the Queen Elizabeth II Diamond Jubilee Medal for his dedication to improving healthcare. I can't think of a more interesting and exciting health reporter and columnists to have on our stage with us today. So welcome, Andre. So without further ado, we have a few questions that people have asked. So I'd like to begin our questions today by asking Andre to comment on something on a more global scale, which is really, it seems that a good job has been done in Canada in pre-planning our response for pandemics in the hospital environment, but there seems not to have been the same care associated with the long-term care system. Why do you think this is?
Yeah, so as we know, we have this COVID-19 pandemic around the world, very similar to what we saw in Canada back in 2003 with SARS. So SARS kind of set the stage for how we responded this time. And SARS was very much a hospital-based disease. So when we heard of this new coronavirus coming along, hospitals were mobilized, and they were mobilized really quickly, and they've responded exceptionally well. And we can almost say they were over-prepared. So they've done really, really well. Now, in our system, hospitals dominate, so we kind of forget the other pieces of the puzzle sometimes. And we kind of forgot long-term care. And we know the consequences. There have been a little over 8,000 deaths in Canada, and more than 6,000 of those have been in seniors facilities. So really a disproportionate 80% of all our deaths have been in these facilities. And if we think back a little, we say, you know, everybody says, why? We should have known, right? These are primed, they're almost designed for the spread of illness. So why weren't we prepared? And I think it's just kind of a whole bunch of factors. We kind of take that sector for granted. It's not publicly funded. We take our elders for granted far too much. And all this stuff has kind of created this virus came along, and it's kind of a perfect storm for ravaging through these institutions, unfortunately.
So is there something that needs to be turned on or turned off when it comes to managing the process in the long-term care facilities from your perspective?
Well, I think we just have to treat them more as part of the health system. Infection control has to be a real priority. We have some pretty basic infrastructure problems. People live in old institutions. We have people living 4 to a room, which should be unthinkable in the 21st century, given what we know about the way diseases spread. You know, we should have hospitals now are all moving to sort of, we say that we use the term one bum per toilet, and that's how it should be in long-term care as well. It shouldn't be people sharing bathrooms, sharing rooms, etc. It just lends itself so well for the spread of illness in this very vulnerable population. So we have to do some pretty fundamental changes. And I think we have to rethink beyond the, fixing institutions is one thing, but we have to think, do people need to be there in the first place? And in some cases, yes, but certainly not the 400,000 people we have in institutions in Canada. They don't all need to be there.
So, Don, from your perspective as a clinician in the acute care environment, what has been your exchange and conversation with your patients and caregivers relative to hospital preparedness versus perhaps maybe what they're experiencing in their own environment?
I think that patients and families appreciate this dichotomy that is obvious between the traditional hospitals and our long-term care facilities. As Andre has mentioned, going forward, we really do have to think about the physical layout in our long-term care facilities. Having 4-floor room is just not acceptable in this world of infectious disease. And I think that a lot of the lessons that we know and that we have incorporated in our regular hospitals are going to have to be incorporated in our long-term care facilities to ensure that problems like this don't continue to happen. So yeah, families are aware, they're aware that there's a big difference between the hospitals and the long-term care facilities. And I think that they're going to be a strong motivating factor for change throughout this and as we go forward.
So, Don, that leads me to our next question, which is really around the best strategies for caring and preventing individuals with dementia and Alzheimer's from contracting COVID-19 and infecting others because of their lack of understanding of the need for compliance within within the health restrictions that are currently upon us. Has the system adapted well? Has it adapted at all? What are your thoughts there?
Okay, I'm gonna start off with a line that a patient mentioned to me just this morning. We were talking about COVID-19, and he referred to it as the other pandemic. And I said, the other pandemic? And he said, yes, dementia and Alzheimer's, that's a pandemic as well. We just don't talk about it. But he said, if you look at the criteria that the World Health Organization was talking about before they made the decision to declare COVID-19 a pandemic, he said, I was sitting there going, they just described Alzheimer's disease. It's a disease of worldwide spread, and certainly if we look at, worldwide, somebody gets Alzheimer's disease roughly every 7 to 9 seconds. It's a lethal disease ultimately. And so it is a pandemic in its own right. And so what we have in this particular case is 2 pandemics colliding. And this has not been a great thing. So if we talk about, individuals with Alzheimer's disease and preventing them from contracting COVID-19, the basic rules apply. We have to do as much as we can to minimize exposure to individuals who have disease or might have the disease. And so the importance of face masks, the importance of hand cleanliness, the importance of wearing a face mask and social distancing with it. All of these are essential, not only in long care facilities, but throughout. Because as we open up the long care facilities and have families going back in, the last thing we want are families reintroducing the disease back into these institutions. So it is absolutely essential that people appreciate this. When I wear a mask, I'm doing it to protect the person around me. And I hope that when people wear a mask, they're doing it to protect me. I see lots of people say, I'm not worried about getting the disease, so I'm not wearing a mask. It's not just you. You could spread it to someone else. And so, just don't think of yourself, think of other people. Wear the bloody mask. I do find that annoying, sorry. So, you got to think of the vulnerable population, and the elderly, and particularly people with dementia and Alzheimer's are vulnerable. So we have to think about that in terms of wearing masks and hand washing. And, going through to the long-term care facilities, I think that we have learned a tragic lesson. Hopefully we've learned it. We've certainly experienced a tragic lesson. And that as we move ahead, we are going to see fundamental changes in how we care for our elderly and how we care for people with dementia. Not having four in a room, not having people with COVID-19 sharing rooms with people who up until that time hadn't had it. And so we just have to use a lot of common sense and a lot of basic principles at preventing disease spread if we are going to, you know, ride this out and have it not continue to spread throughout our most vulnerable population, those with dementia and Alzheimer's.
Thanks, Don. Andre, when you're talking to people researching for your articles, and I would suspect that you come across many who say, is it really necessary to go to this level? Is it really fundamental to containing the spread? Has that been your experience? I'm only assuming that might be your experience. And what do you say, what evidence do you give them from your research and your stories and the others you've been talking to about the importance of universal precautions and what we have in place currently?
Well, you know, views go right across the spectrum. So there are the people who are like, oh, I don't want anything to do with that. This is all a hoax, right through to people who think we should never, ever leave our homes ever again. So there's a wide range of views, and you have to, you know, people have different views of risk and how they perceive risk. So it's all over the place. And I think generally, though, people recognize that this is you know, it's a novel coronavirus, meaning theoretically we're all at risk. And people, I think most people recognize that. And they also recognize that there are populations that are far more vulnerable, especially elders and especially those in institutional care. Because we know, you know, almost 2/3 of people who are in our institutions in Canada have some form of cognitive decline, right up to Alzheimer's and other forms of dementia. So it's a really difficult, you know, as Don said, a difficult group to try and get to obey the rules, if you will, if they don't understand the rules. So we have to be extra cautious with them. And that was difficult in long-term care homes because they're, one of the biggest problems they have is being understaffed. So they're, you know, if you don't have staff to do the basics like feed people and change them and clothe them, you know, you can't expect them to make sure they don't intermingle. So there has been real issues with that in homes, and it's not an easy issue to deal with. But again, it just, I think everything about COVID just really focused a spotlight on issues that already existed, and the state of how people with dementia are treated in homes is just one of the many issues that's been exposed.
So that leads nicely to our next question, which is really how many people I've spoken to feel, which is that they don't want to place a family member in a long-term care institution since COVID has revealed some of the weaknesses that are a part of that system. So how do we get more home care, Andre, help for people with family members with dementia who may need that extra help? What are some of the potential alternative solutions?
Yeah, so we only have an hour, so I'll try and be brief. But you know, it's really, I think it's about adopting a fundamental philosophy. We have to stop asking the question, is there room in long-term care? We have to stop making it the default, and we have to start asking the question, where is my loved one best cared for? Sometimes it'll be at home. Sometimes it'll be at home with a lot of respite care. Sometimes it'll be in an institution, but we have to make the care appropriate to everyone. And we don't do that. We have this Ministry of Long-Term Care is a ministry of putting people into institutions where they don't want to be. You know, I do lots of talks, and I often ask people, who here would like to live in a long-term care home? No one has ever raised their hands. You know, I've spoke to a group of long-term care owners and none of them raised their hands. It's a fundamental problem that people are scared of these places, and for good reasons in some cases, but we have to remember sometimes care is necessary. I had parents with advanced dementia who had to be in an institution. They weren't safe at home. But what we have to do is make sure that home is right for them and safe for them and gives them a quality of life. That's what it's about. It's about giving people the ability to live up to their abilities, whatever those are, and have a quality of life and a quality of death. And that has to be the starting point of our discussion, not how many people are on the wait list.
It's interesting in the context of providing quality of care and quality of life. And Don, I know you dealing in your practice see that every day and the challenges that people face. What are they saying to you about their fear of the potential of going into a long-term care facility or something where they won't necessarily have the kind of quality of life that they're expecting or that their caregiver or loved one expects for the patient?
Yes, they're scared, and rightfully so. They look at the statistics, the numbers which have emerged over the last several months, you know, they have concerns. The one that I'm seeing now is people are being contacted saying, "Oh, there's positions opening in long-term care." Well, they know why there's places opening in long-term care, and they're going, "Isn't that nice? I don't want to be the next person in that unless fundamental changes have occurred." You know, they really are expressing a whole lot of concern about that. They also express concern about, yes, we have universal health care in Canada, but do we really? Depending on where you are geographically, access to various types of long-term care vary from region to region in this country. And so, you know, it is highly variable. You know, let's face it, the best place to be is probably at home for most individuals, although that can put an awful burden on the family. And so this is always a juggling act of being at home and having optimal home care with the family feeling tremendous sensations of guilt sometimes that, you know, putting a mother or father into a long-term care facility represents somehow a failure on their part, which it isn't. So I think that people are right now reticent and reluctant with good reason. And they are looking to government and to the regulatory authorities to put in some changes before they will have the comfort that they need in going forward to fully trust this process.
So I think that's a fair assessment, and certainly a challenge both systemically, financially, and structurally, with lots of debate that's currently going on. We're not going to solve this issue overnight. But one of the questions that is emerging more acutely, perhaps, than we have seen in the past is really about the concept of separation from family and loved ones. And one of the questions that came forward from our community who's joined us today is really about whether or not separation because of COVID is going to cause harm or regression to those who are suffering from Alzheimer's and dementia. Or will the lack of opportunity to see someone in person, live, give them a hug, whatever that may happen to be more difficult on the family rather than on the patient? Don, what's your perspective on that?
If we go back 6 months pre-COVID, if I saw a patient and a family in clinic and they had mild cognitive impairment or an early phase of dementia, and they were saying, you know, what should I be doing? I always said, social engagement, keep active, keep involved, and physical activity, get out, go for a walk. You know, I said, probably those two things contribute more to your well-being than any medicine that I could come up with. Fast forward till now, and you go, well, I've taken both those things off. They can't have their physical activity. They can't have their social interaction. Many people have been isolated to rooms. And yes, this is definitely difficult on the patient, the person with the disease or disorder, and it's certainly very stressful for their family as well. And it's a teeter-totter. It's you're damned if you do and you're damned if you don't. You don't want them to have or to get COVID-19. On the other hand, we don't want to err on the side of isolating them. As Andre said earlier, there's some people who think that they should just stay at home now for the next year or two. Well, that's also not a solution to this. We need a happy medium. We need to have in place sufficient protections that these people don't get exposed to COVID-19, but we also have to put in place opportunities for them to interact with their families and to have those meaningful interactions which are in fact therapeutically beneficial for them. And so as we get through this, we're going to have to put into long-term care facilities, for example, improve methods so that people don't get to endure exposure to COVID-19, but do get to experience the benefit of interactions with family members and others. And so just to answer the question, yeah, I think that prolonged separation does cause harm, does cause some regression in those individuals. And I think that, we've gone through this acute phase, but now we have to start opening up, but do it with extreme caution. And we have to strike the proper balance of minimizing risk and maximizing the opportunity of beneficial interactions.
So Andre, in your experiences of chatting with people, I'm sure you've come across the concept of individuals are feeling like distance is maybe having an impact on their family or their loved one who's in a facility, or even at home, people who have mild cognitive decline, but you can't necessarily have that interaction with them other than digitally or through a window, perhaps. What are individuals saying to you about the worries that they have around that kind of decline?
Well, I think people recognize there was some, severe infection control that had to be done at the beginning. We had to get a grip on this, especially in homes with COVID. But it's gone on now. People have been locked out away from their loved ones for more than 100 days now. So it's become cruel. It's become almost like social isolation imposed on people who don't understand it. It's especially, I think, harmful to people with dementia. They don't understand why they're in this situation, why they can't see people. And we're in the situation where literally thousands of people have died without loved ones at their side. And people will never get over that. That's cruel. And it's the mourning process is so important to us, to adjusting to life. These are really fundamental psychological and societal things that we've denied to people. And doing it for a bit was necessary, but it's gone way, way overboard. We have to remember too that caregivers, family caregivers they're not visitors. They're not there for a picnic to bring a birthday cake. They're doing fundamental stuff, interacting, feeding, dressing, keeping people alert. As Dawn said, it's so important to your health to socially interact, especially in this earlier stages of dementia. And we've denied people that. And I think we'll learn over time as the research comes out that we've done great harm to people. And I don't think it'll ever be correctable.
You often hear the term necessity is the mother of invention. Do either one of you have any stories about how people are sort of trying to navigate this particular challenge about being distanced or separated? Is there anything that comes to mind for you, Dawn?
Well, it's very challenging for these patients. I was just noticing that someone had commented in the questions coming in, was taking issue with the statement suffering with dementia. So I thought that I would actually comment with this. People have dementia, and the word suffering is a word which means a lot to a lot of people. They are experiencing frequently, I notice that people are experiencing Alzheimer's or dementia, and their family is suffering. This is a disease of the entire family. So that's why, when we get back to this whole issue of reuniting families so that they can meet, this is therapeutic, not just for the patient, but for the family. This is therapeutic for everybody. So, as I mentioned earlier, this is a careful juggling act, but, Andre said, some of the things that we've done have bordered on cruelty or have been cruel. And I think that's true. So, it's just time to move on and to minimize the risks and maximize the benefits, as I said.
Speaking of moving on, our next question really focuses on how close the medical community is to an intervention that will treat dementia. And the sort of the accompanying question to this is, given COVID-19, were any of the clinical trials delayed or stopped? Don, I'm sure that you have a great insight into this question.
Okay. Well, I'll follow up with what Andre said. Oh, since we only have an hour, in January, on a cold January day this year, it was like minus 25 or something outside. I was seeing a patient, and the family said, "Oh, we had Googled you." Unfortunately, they all Google you before you get seen now. I learned so many things about myself from my patients. One said, I see you're a person who's actually like tries to design drugs for Alzheimer's. You had some to go to clinical trial. Have any been successful? And I said, would I be sitting here today on a minus 25 day talking to you if they had been successful? You know, the last 204 clinical trials, I keep track of them, in the broad area of Alzheimer's and dementia have not been successful. The medications that are out there are called symptomatic. They're not disease modifying. They don't affect the natural history. And when we talk about the medical community moving forward, I'd like to think of it in two broad areas. The first is diagnostics, and the second is therapeutics. So the first is diagnostics. It's not, we don't have, you know, the blood test where, you know, I can measure your serum Alzheimer's factor and say, yep, you got it. We just don't have that. And so there is need for advances, not only in the development of interventions and treatment, but also in our ability to diagnose this. That having been said, do we have anything that's going to come up shortly? No, but we're a lot further ahead than we were 10 years or 20 years ago. We are getting close, and there are a lot of very interesting agents coming along, both biologics, which are larger molecules, and more small molecule agents that really are tackling the fundamental protein misfolding or the fundamental brain inflammation that occurs. And so certainly one would like to think that, yes, we're going to have, I think, a diagnostic sooner than a therapeutic. But I think that there's, in the next 5 to 10 years, there's reason for significant optimism in both those areas. Now, the second part of this question is, given COVID-19, were clinical trials delayed or stopped? Yes. I mean, most clinical trials are involved in hospitals, and people really didn't want to line up and come sit in hospitals over the course of the last 3-4 months. And so there has certainly been a slowing down of these clinical trials, and certainly in the hospital in which I work with, the University Health Network, we're just starting to get a lot of our clinical research back up and going now after a 3-4 month hiatus. And so things have been slowed down, yes, but they're starting to pick up again.
So it's interesting. I think of the Krembil name and the persistence or relentlessness with which researchers pursue cures in the environment.
Yes.
And the challenge around clinical trials and individuals understanding the length of clinical trials. But how much, I mean, from the beginning of your career to now, and what we're seeing with COVID as an example of this, is how much has technology advanced in order to be able to shorten the life cycle to get to the drug? And will there be advances that move more quickly as a result of technology enhancements in the environment of drug discovery?
Excellent question. Well, I mean, one of the big problems here is it's not like you're developing an antibiotic where you're going to know in 7 days if it worked. This is a disorder that unfolds over the course of months and years. And to really know if your therapeutic is working, you got to follow these patients for that corresponding period of time, months or years. And so the clinical trials can't be rushed. And if you really want an effective therapeutic. But the techniques that we use in designing molecules and in advancing molecules, they have improved. And so I would like to think that we will go down fewer blind alleys, and we will stumble a little less. We're still going to stumble, but a little less. And in doing so, the process becomes iteratively a bit more efficient every year. And so hopefully we'll be able to narrow in on drugs that are worth clinical trials and be able to move this along faster than we have traditionally.
So an interesting perspective, which actually leads really quite nicely into our next question, which is maybe a little bit controversial in nature, which is the concept of researchers taking advantage of populations in the long-term care environment. Many of them, as Andre referred to before, who have cognitive decline. And this particular example comes from Halifax. Is there a real opportunity here to look at a very unique population relative to COVID to be able to advance care and diagnose or impact a particular population that may be potentially different than other populations who have been struck with COVID and may have longer term results? I pose that to you to start, Don, and then Andre can fill in the blanks afterwards.
Well, I like this question. Before I moved to Toronto in 2013, I was a neurologist at the QE2 hospital in Halifax for the previous 13 years. And did indeed see a number of individuals from Northwood in my many years in Halifax. This is an interesting question, and depending how one reads it, it can be interpreted in multiple ways. Certainly, one has to be careful in doing experimental studies on residents of chronic care facilities. Under ethics, we have to have full participation of the patient and their family, and we have to respect the wishes of those individuals. And so certainly when we see, people in long care facilities, we can't just say, well, that'd be neat to take their blood and study them. It would be in many instances, but this has to be handled in a very careful and sensitive way, which, respects the need for privacy and the need for complete informed consent. There are a number of unique populations across Canada, and studying them for their ability to get through COVID-19 or have varying courses in other types of dementia certainly represents a wide range of opportunities. But I'll also follow up on something that you mentioned, Leslie, to begin with. CIHR chooses only to put about 5% of its budget onto dementia and Alzheimer's, which, from my completely and perfectly unbiased point of view, as a dementia researcher, is just horrendous. I think that, we have to look down the road. This is the other pandemic, or the original pandemic. We really should be doing something about this. We have lots and lots of research opportunities. We really do need the funding and the opportunities through CIHR, through the Alzheimer's Society of Canada, who support this sort of work to move ahead. And so interesting idea and probably worthwhile, but certainly one has to be sensitive in pursuing such opportunities.
So Andre, not that I want to shape your answer, but Don talked about lack of research funding. I'd like to tie that to our next question, which is really around the opportunities that COVID-19 has provided for us to learn more about the pressing gaps in dementia care in Canada, research potentially being one of them. What other opportunities has the collision, to use Don's term, or Don's patient's term, the collision of two pandemics really brought forward for us?
Yeah, well, COVID has brought forward, this scientific outburst. We've had incredible amounts of research. I was just reading yesterday, there's 1,000 scientific papers a week being published about COVID. So there's been this unprecedented mobilization around the world. But I think moving forward, that's what we have to do. We have to say, what opportunities does this provide for us to look at other things? Long-term care is an obvious one. We don't do much health services research. We do a lot of sort of in the lab research, which is of course very important, but we also have to look at the structure of our systems. And that was the big failure here, was structural. So we have to invest some of that there. And I think a subset of that is going to be these most vulnerable patients, those with dementia. So I think there's definitely opportunities here. One good example, if I can tie back to the last question, is antibodies. This is going to be one of the real key questions in the world going forward. If we've been infected, we develop antibodies, but How long will they protect us for? So will we have immunity? That's really the billion-dollar question here in COVID going forward. And it's especially important for people in care. If, for example, I've been infected, I have immunity, and I know it's going to last, then it's safe for me to go visit my loved one in a home without further protections. So that's really, really important. We need to know if people living in the homes, we know how many have died, but we don't know how many have been infected. Are the rest of them safe? Are they not going to catch it in the future? We don't know this stuff, and it's really important. And again, I come back to it's doubly important for the most vulnerable.
So certainly more questions than answers at this stage of the game, for sure. I mean, we here at MedicAlert are also very interested in health systems research and the impacts around social determinants of health. I think that's really one of the fundamental things that will help to advance things moving forward, which is a nice segue to our next question, which is really around the fact that the pandemic has accelerated shifts in our society, things like working from home that we never thought was possible, but we're all doing it. Cycling, guaranteed incomes. There's all kinds of things that are emerging in that concept of, as I said before, necessity is the mother of invention. But how has the pandemic expanded that range of options being considered? I mean, Andre, your work is about probing for those options in many cases. And what are people saying to you? What are experts, non-experts, families, friends really pressing for that might have been something that could have taken years to evolve, but now really, in theory, could take weeks or months to emerge?
I think there's a couple of things that are really changing dramatically. One is virtual care. So in the past few months in Canada, the majority of care has been virtual. That's a sea change overnight, something we've talked about for 25 years, and we've finally done it. And people like it. Most patients love their virtual care. Physicians are adjusting to it. Some of them don't like it because of the payment schemes, but it works. So that's a really fundamental one. I think the next big one is this notion of what we talked about earlier is how can we give people choice about where they age? Most people want to age in place. They want to age in their home or in their community in some form. And we don't allow them to do that now. We default them to ship them off somewhere into an institution. So that's going to be a real fundamental change in society that I think this demographic is going to demand. The older, the boomers are going to demand this choice. And COVID has really, really accelerated that and I think given more to their voice. And this debate, we've had this debate for a long time. I've been writing for 40 years about journalism. We've been talking about home care for at least that long, but it's always come down to, well, home care is too expensive. And I think we have to challenge those myths. I don't think that's true. It depends who we deliver it for, how we deliver it, what the alternative is. Yeah, it's more expensive than shoving 4 people into a room, but that's a non-starter now. So home care becomes more affordable and it becomes something people want. So I think we're going to have a really serious discussion. There's going to be, Canada loves to do inquiries after tragedies. So there's going to be inquiries. My real hope is that our inquiries are not just about how do we fix the buildings, the inadequate buildings, how do we make them slightly less inadequate. That's not what we need. We need to think an inquiry to tell us how do we give every person the right to age in place or where they want to.
So off the top of your answer, you talked about virtual care. One of the questions that I wanted to pose to you in particular, Don, because you've had to shift your practice, is how has technology changed the way we care for patients with Alzheimer's and dementia during the pandemic? What does that look like?
Well, I'm one of those physicians that Andre referred to who is grappling with the change in how care is delivered. And yes, I agree that some physicians are struggling to cope with this new model, but I will say that the patients aren't struggling nearly as much. They have embraced this enthusiastically. As they say to me, getting mom or dad, bundled up and into the car and driving down to Toronto Western Hospital and finding non-existing parking and trying to get him into the hospital. This is absolutely wonderful. And they usually end their interactions with me is when COVID's over, we're still going to do this, right? And so I go, yeah, I mean, you know, they don't need to be put out. There are times when actually seeing the patient is crucial. But I mean, a lot of the routine follow-up and stuff like that, you know, they don't have to be. We can do that just as even more efficiently over a video sort of link. And so it certainly changed the way we deliver care. Now, you know, adapting to using computers and stuff like this, the 70 and 80-year-old groups don't do that quite as well. And so there have been a number of glitches having family members involved in order to facilitate using the technology. But, you know, despite their underlying issues, most people seem to be coping with it reasonably well. You know, this, I think, has been a catalyst to move to the future in this regard. It's probably something that we should have been looking at and doing a lot more seriously over the course of the past 5-10 years as video techniques have been improving. But COVID-19 has really catalyzed this and moved it ahead. And I think that this is a tragedy which has some positive outcomes, and this might just be one of the big positive outcomes.
So interesting shift for sure. And
yes.
Certainly something that we here at MedicAlert are considering in the concept of what we can offer to our subscribers to be able to support their health and wellness overarchingly. Before we're getting close to the end of our hour, and there are a couple of really key questions that I would like to ask the two of you. The next one is a bit of a blue sky question, but nevertheless, I think a key one for our audience. And Don, let me start with you, which is based on your experience, knowledge, understanding clinically, pharmacologically, and any other perspective you'd like to bring to the table. What do you believe will be the long-term implications of COVID-19? For your patients and those with Alzheimer's and dementia? Or can we tell?
Well, we can't tell, but we can certainly look down the road. First of all, I think that the COVID-19 crisis has shone a light where perhaps we did not want a light shone, and has drawn attention to some issues in terms of the delivery of care that we do for people with dementia and Alzheimer's disease and cognitive disorders. By doing so, it's regrettable that the tragedy occurred, but as we've been mentioning along, it hopefully will motivate real change not just in the mortar and bricks, but conceptually and just in how we enable people to age meaningfully and age happily as they move forward throughout the phases of their life. So I think that has been worthwhile. The next issue is the one that we were just talking about, and that is telemedicine or video visits and care. That is going to stay after COVID-19. We're looking at that in the long term. That's here to stay, and that's a good thing. And I think that, you know, families will be able to keep in touch actually better than they have been able to do so with their healthcare providers. And so I think that is useful. The final comment that I'm going to make is a bit out there in terms of the pharmacology, because you dared to use that word. COVID-19, the people who get COVID-19 frequently get a severe inflammation of their lungs. And so we call it a cytokine storm, but certain inflammatory chemicals called cytokines build up in their lungs. And believe it or not, there is now a belief that Alzheimer's disease has an inflammatory component. And so there's an emerging strings of evidence in the research world that says that lessons we're learning from treating COVID-19 may actually spill over to dementia. And I think that also is a long-term thing that we could not have anticipated, but one that has some good future associated with it.
It's interesting. It's like that drop in the water that has a ripple effect, not specifically related to one disease, but multiple sets of diseases associated with it, or comorbidities, if you want to use that terminology. But Andre, in your experience as a reporter, as a journalist, as somebody who has championed healthcare throughout your career, your role, interestingly enough, as I see it, is knitting things together. So if you were to knit the blanket of the future, to use a terrible metaphor, but what does that blanket look like from your perspective? What does COVID-19, a point in time experience, actually mean for the future of individuals with Alzheimer's and dementia?
I think what it's going to do is make people less accepting of the status quo. Like in Canadians, we're pretty, okay, well, I guess that's what we have to do. And, it's covered by Medicare. So we kind of go along, even if we're uncomfortable with things, we kind of accept them. And I think there's going to be less acceptance. There's going to be more demand for home care. There's going to be more demand for virtual care. There's going to be, I think, more thinking about quality of life. We've seen hundreds of thousands of people denied their quality of life in institutional care because of this bug. And I think it's going to make us rethink. I think we often forget that those of us who've had parents with loved ones with dementia, that's the key. It's making sure they have the best life possible. And we've denied people that for maybe a good reason, but for far too long. And I think we have to just extend those kind of conversations more broadly. We should have had them before COVID, but let's have them after COVID, better late than never. But I think those really fundamental rethinking about how we age, where we age, how we treat people with disabilities, whether it's dementia or mobility issues, I think all these big questions are upon us now because of this little bug.
It's interesting. We've had an hour to cover an immense amount of ground. And certainly have not done the topic justice, given the number of questions that we received from our audience today. But if each of you, and let me begin with you, Andre, if each of you could sort of summarize from your perspective the top 3 things that you would like our audience to take away from this discussion and your experience of dealing with Alzheimer's and dementia, what would those 3 things be?
I think the two most important ones for me would be, first, to get the pandemic out of the way. I think we have to learn to live with COVID rather than in fear of it. So we're humans, we're very, we fix things, we find solutions, and we're doing that with this pandemic. We have to figure out how to live with it. It's changed a lot of things in our lives, but it's changed a lot of things for the better. So let's learn to live with it. And I think that larger question carries over to how we live with dementia. We have to figure out, many people are going to get dementia where there's no silver bullet. Even though Dawn's working really hard to find one, there's not going to be one in the immediate future. So let's make people's quality of life the best possible. That to me is the goal. It's not all about drugs and stuff. It's about making people comfortable, making sure their caregivers have respite care, making sure that they, if they wander, that they're found safely. Really basic stuff. And I think the third point would be that. I think this is what COVID has reminded us of more than anything, is the basics really matter. You have to have a good income to have a good life. You have to have social connections. Those are so important. And public health is this invisible friend that we have that has become magically visible and has really done dramatically good things for us.
Thank you. And Dawn, what are the key takeaways from your perspective that you would like our audience to hear from you?
Number 1, we're not through this. I think a lot of people go, yay, we flattened the curve. Everything, we can go out and do what we want. No, we're not through this. We don't know if there's going to be a second wave. We don't know what's happening. This may be a part of our life for years to come. And so we have to adapt to it, and we have to accept the fact that this road's got more bumps in it. Secondly, even though the road's got bumps in it, there's room for optimism. I think that down the road, we are learning about COVID-19, we're learning about dementia and Alzheimer's, and these lessons are going to let us improve how we treat these individuals. And the third point is that it has emphasized the need for comprehensive care. As Andre said, care is more than a pill. care is taking care of the individual from all aspects. This is a full court press to take care of the needs in their lives in multiple ways. And I think that the COVID-19 tragedy and what we're going through right now has certainly emphasized the need for this comprehensive, and I think this is a lesson which has been learned.
So, I want to take the time to thank both of you. I've learned a lot today. I know I will continue to learn in the questions and the answers that we are trying to provide for people of this audience and the broader audience of the 1.1 Canadians who are impacted in some way, shape, or form by Alzheimer's and other dementias. So on behalf of MedicAlert and our partner, the Alzheimer's Society of Canada, thank you so much for your wisdom and your insight. And you are welcome back to Health Hour Live anytime. So
thank you.
Special thanks again to our partner, the Alzheimer's Society of Canada, for their input and wisdom and knowledge and understanding that we will continue to build upon as we continue to answer other questions that came through in Health Hour Live. And with that, I would like to thank everybody who has joined us today. Please stay tuned. This is the first of many interesting topics on Health Hour Live, and we invite you to come back again and join us. Until then, thank you very much.